Try sharing it. Yeah, once you try sharing it. Did you try sharing it?
Not yet.
Yeah, just try and see.
Can you see it?
No.
Not yet. Yeah, it's come. Yeah, it's come.
Okay, fine.
You have to do the slideshow possibly after this, right?
I don't know, but it's not showing everything. It's taking time to upload.
Excuse me.
Can you see it now?
I think
Actually, we can. Yeah, that's fine. Now it's okay. That's fine.
Fine. Okay, good.
That's fine. Ashanti, start off. Chalo, introduce the speaker. Dr. Amita will come. It's already 11, I think 4 past.
Yeah.
She's not able to join. She was telling she's there. I'll ask her. Please.
Yeah, you introduce the speaker. Go ahead. Actually, she's written everything on the slide only, I think. Yeah. So you did, you're already a professor?
Yeah.
Yeah, you are already a professor, right? Okay.
Yeah, I was told to put that first slide so that anyone who is introducing me can.
So you had worked in Sloan Catering also for 2 years?
Yeah.
That's a good exposure. Yes. And you did your MD from?
From Government Medical College, Mirrors. And then I did my
Okay,
diploma in
Meerut.
American board from New York Medical College.
Yeah. Yeah, one has to have, actually, you keep on doing it. So can we start the presentation, Dr. Asranti? We should start, I think. You may start
Madam,
your
she is not
presentation.
able to join. We can start, madam. She might
Yeah,
join.
it's okay. I think her details are available on the slide.
Yes,
so she can go ahead. You start presenting,
madam.
make your presentations.
Yes,
Sure,
madam.
Yeah,
definitely.
Dr. Asawari, please start.
Okay, so thank you very much, Dr. Kim and Dr. Asaranti. I thank.
You have to speak louder, but right? You have
Can
to
you
speak
hear me
louder.
now?
Yeah, it's I can hear you, but slightly louder.
Okay, so I thank IIPM body and Dr. Kim and Dr. Asaranti for giving me this opportunity to interact with the PG students. And without further delay, I would like to say this is just a teaching purpose presentation, and it has been compiled from our center, Tata Memorial Center, as well as from textbook, as well as from internet. No conflict of interest. So we are going to discuss today approach to the diagnosis of salivary gland tumors and use of ancillary studies. So why it is important diagnose salivary gland tumors? That way they are like these are small glands scattered everywhere through upper aerodigestive tract, and also there are major glands, and the incidence of tumors is not that high, but the variety of tumors and the diverse nature of these tumors, they pose diagnostic challenges. These tumors are very uncommon, include morphologically diverse tumors, and they show overlapping morphological features. The morphology is also complex. They can show hybrid tumors, benign tumors progressing into malignancies, or low-grade tumors progressing into high-grade transformation. All permutation combinations are possible. Global incidence, if you have to see, it is varied, ranging from less than 1 to almost 13 cases per 100,000 population, and approximately 0.3% of all malignancies, 6% of head and neck malignancies. But incidence of malignant and benign salivary gland tumors, it varies according to the location of the tumor. How it differs, because we know that there are 3 major salivary glands, 2 parotid glands, submandibular glands, and sublingual gland, and there are many minor salivary glands scattered all over in the upper aerodigestive tracts. And if you look at this, majority of the tumors are located in the parotid gland, followed by minor glands, and then submandibular gland. If you look at the distribution of benign and malignant tumors, parotid gland harbors almost 75% of benign tumors, while this percentage goes down when we are dealing with submandibular gland tumors. And when we come to minor salivary gland tumors, majority of them are malignant. Now, WHO classification, if we go look at the 2017 classification, there are 11 types of benign and 21 types of malignant tumors of epithelial origin of salivary glands. Treatment decision is mainly based on stage of tumor, location of tumor, grade of tumor, whether it is low grade or high grade. And it is very important because 5-year survival rate is better in low grade tumors, but it is for just 40% in high grade salivary gland tumors. Now, as a pathologist, what is our role? We have to diagnose these tumors and we have to tell the surgeon after the resection whether it is complete resection and whether the patient will need any further uh, adjuvant therapy or not. So if you look at the role of the pathologist, it is at the 4 levels: FNAC, biopsy, frozen section, and resection specimen. Now, if we look at the FNAC, the first line, it is a first line diagnostic approach for triaging majority of the cases. First task for the person who is interpreting the FNAC is whether it is a neoplastic lesion or it is a non-neoplastic and inflammatory lesion. That we have to tell because all the non-neoplastic or inflammatory lesions, they will require usually conservative medical treatment. Yes. Am I audible?
Yeah, it's fine. I think it was a disturbance. Please mute all your speakers, please. You continue. It's okay.
They are muting me, actually. Okay. So,
Yeah, that's fine.
okay. So, neoplastic lesions will require conservative treatment, but neoplasms, all kinds of neoplasms, benign and malignant, will require surgical excision. Now, when it comes to malignant neoplasm, all of them, they will require surgical excision with adequate margins. But when we consider our low grade versus high grade cancers, surgical resection with adequate margins is enough for low grade cancers of salivary gland, but high grade cancers, in addition to surgical resection, they will need either regional node dissection sometimes or sometimes adjuvant chemotherapy or radiotherapy. Can we stop that disturbance? Somebody's talking.
I think there is Sunita. Who is Sunita? I think please mute yourself.
Dr. Sunita, someone, yes.
So when
Yeah,
we
I think she's mute herself now. That's fine. Go ahead. Go ahead.
So when we are discussing about malignant neoplasm, low grade versus high grade cancers, and all of them require surgical resection, one thing we have to remember is lymphoma. And we know that lymphomas, they will not need any surgical resection. It is just the chemotherapy and any other adjuvant treatment. So this is how we are required at the level of FNAC. We have to tell them whether any surgery is required or not, and if possible, surgery extent of the surgery. Now, this I'm not going to go into the details, but there is this Milan system for reporting of salivary gland pathology, and there are like 6 categories we are aware of. Bethesda system for thyroid, something similar to that. The first one is non-diagnostic, then second is non-neoplastic, then ATP of undetermined significance, benign neoplasm, neoplasm of uncertain malignant potential, suspicious for malignancy, and malignant. In malignant, if possible, we have to say low grade versus high grade. Then second is biopsy of salivary gland. The biopsy of major salivary gland is not that commonly obtained. But minor salivary gland, usually they are diagnosed on biopsy, especially oral mucosa or upper aerodigestive tract mucosa-based lesions. It is also essential when lymphoma is suspected in FNF of any major or minor salivary gland neoplasm. Again, at the level of biopsy, when we are looking at the biopsy, we have to give the diagnosis, benign versus malignant, and try to give them grade of the tumor, low grade versus high grade. Role of frozen section. Now, it is controversial, although many surgeons ask for it, especially when the diagnosis is not clear and whether the lesion is neoplastic or non-neoplastic or benign versus malignant or low grade versus high grade. But most of the times, usually the frozen section will be for complete resection is done or not, or if the nodes are positive or not. Now, role of frozen section for primary diagnosis of malignant tumors. It has a somewhat low accuracy, almost 86%, but benign, it has higher accuracy, and still it can be used to decide the extent of surgery and nodal dissection. So just I want to share one case. This was FNAC of one of the, they said it is level 2 nodes, and it showed this kind of epithelial cells. We thought it is metastatic tumor. But at the frozen section, they sent this node, and all of you can identify this as this was a Warthin's tumor. So this was nothing but the Warthin's tumor at the tail of parotid, which can mimic as a level 2 lymph node, and this was further confirmed on paraffin section. Now, resection specimen, these are the essential parameters we have to describe, starting from tumor site to the pathological stage. It also includes tumor type, grade, and extent of invasion. But now we are going to look at the histologic types of the salivary gland tumor, which is today's topic. And if we look at the WHO classification 2017, this is the classification. Now we are expecting revision of the classification in 2022 update, but it is still the print is, or even online version is there, but print is still not out. Now, major histological types are epithelial tumors, benign versus and malignant, and mesenchymal, hematolymphoid, and metastatic tumors. And there is this big list of the tumors, which is malignant tumors, then borderline cyeloblastoma, and benign tumors. Now, why it is important to identify histologic type of salivary gland tumors? Because I said we have this low risk versus high risk cancers. We have to differentiate between them. And this is a big list of low risk neoplasms in the salivary gland tumor, and high risk usually adenoid cystic carcinoma with solid component, high grade mucoepidermal carcinoma, salivary duct carcinoma, squamous cell carcinomas, lymphoepithelial carcinomas. All of these are high risk. Again, invasive carcinoma, pleomorphic adenoma with high grade tumors, adenocarcinoma or cystadenocarcinoma of high grade, all these are high risk tumors. So let's just focus at epithelial salivary gland tumors. And to understand epithelial salivary gland tumors, we need to understand the histogenesis and histology of the salivary gland tumors briefly, because that points out towards the diverse nature of salivary gland tumors. Now, salivary glands are composed of multiple acini connected with the ducts, and this is the ductoacinar unit, which is a bilayer composed of inner layer of luminal and outer layer of abluminal cells. Now, luminal cells are these acinar cells, intercalated cells, striated ductal cells, abluminal are myoepithelial cells, and basal cells. And as you can see here, this is the salivary duct in the left-hand corner. Then there is this is, I mean, that's a secretory part of the duct. And intercalated duct, we have this acini. Some of them can be showing mucinous cells, some of them can be showing serous cells. Then there are abluminal cells at the periphery, basal cells, and myoepithelial cells, and there will be basement membrane. And this is a schematic diagram showing the same acinus with myoepithelial cells at the periphery. Then there is this intercalated duct, striated duct, and excretory duct. This is HE section, which is showing striated duct here with two layers nicely visible. Now there are ISC markers which are specific for luminal cells and abluminal cells. Mind well that myoepithelial cells can express sometimes pancytokeratin, although they are not that strong. So this is just to show you how colpotin can highlight myoepithelial cells around the acini. Again, P63 can highlight myoepithelial cells, while this is EMA or epithelial membrane antigen showing the luminal cells, ductal cells. Now, why it is important? Because there are different tumors arising from different parts of this ductoacinar unit. So usually acinic cell carcinoma will arise from acini, while this portion will give rise to pleomorphic adenoma, adenoid cystic carcinoma, and so on. Striated ducts will give rise to Warthin's tumor, oncocytoma, and rest of the ducts like secretory duct, they will give rise to mucoepidermal carcinoma or other adenocarcinoma, NOS, or salivary duct carcinoma. So this will help us to understand diverse nature of the salivary gland tumors. This is another diagram showing the same. All of these are available on internet. So like luminal cell will give rise to canalicular adenoma, basal cell adenoma will show two-cell population. Again, pleomorphic adenoma will show two-cell population. Myoepithelial predominant tumors or myoepithelioma will show myoepithelial cell population and so on. Now, there are further challenges in the diagnosis because there are different types of epithelial metaplasia can be seen in salivary gland tumors like squamous, oncocytic, clear cell, mucinous, or sebaceous. Again, the architecture or pattern can be different, cribriform, tubular, papillary, and so on. So how do we approach or how do we proceed? What are the steps in the diagnosis of epithelial salivary gland tumors? First and foremost is morphology, morphology, and morphology, and that is a good HE10 section will give you almost always the entire information, and sometimes you will need ancillary studies to just to confirm, or in case of differential diagnosis, they will be essential. So diagnostic is usually HS10. Even HS10 can guide us to decide what ancillary studies we should be selecting for further differentiation. Ancillary studies include immunohistochemistry and molecular genetic studies. Usually they are used for objective evidence to support HE diagnosis, sometimes for prognostication, and nowadays for targeted therapy or therapeutic stratification, they are essential. So coming to the HE section, what are the important uh, steps in the HE section we should be observing uh, before we proceed for the diagnosis of salivary gland tumors? First and foremost, when you look at the section, now this I'm talking about excision specimen when we are talking about borders of invasion, but sometimes even a biopsy can be helpful, especially when we are looking at oral mucosal biopsies. What we have to look at is whether there is circumscribed or there is lack of invasion versus infiltrative. Now, infiltrative doesn't mean always infiltrative in small clusters. It can show a pushing lobulated border. If we can spot perineural invasion or lymphovascular invasion, it is always helpful. Now, once we know whether it is invasive or not, then cellular composition. Now, cellular composition, what types of cells we are looking at, whether it is one cell population versus two cell population, what is the morphology of the cells, and what is the architecture or growth pattern. And in addition, stroma also is useful if when present, it can help in diagnosis of the tumors. So let's look at this algorithm described by Dr. Katabi and Binshu for diagnosis of salivary gland neoplasm. First, we look at non-infiltrative versus infiltrative, benign versus malignant. Now remember, usually well circumscribed or non-infiltrative tumors are benign, but that's not always true. Tumors like pleomorphic adenoma can show lobulated pushing borders or islands sometimes, especially when they are recurrent tumors. Now, infiltrative margins usually almost always are malignant, but again, pleomorphic adenoma is one exception for that. Then you look at two cell types versus one cell type, and what is the type of the cell, whether these are oncocytic, acinic, any squamous differentiation, and so on. So let's look at it one by one. This we already discussed: tumor border of invasion, circumscribed versus invasive. If we spot LVI, PNI, that is again helpful for diagnosis of um, uh, in malignant tumors. I'm sorry for this mistake. This is invasive pattern is usually seen in malignant tumors, not in the benign tumors. So this is just to show you one pattern of benign tumor showing circumscribed tumor with this benign salivary gland in one corner. While this is a tumor, now here it may look like circumscribed, but you can see that there are small nodules showing pushing pattern of the invasion. Now coming to the cell type, one cell type versus two cell population. Now there are many tumors that are showing one cell type, that is acinic cell carcinoma, polymorphous adenocarcinoma, secretory adenocarcinoma, salivary duct carcinoma, and so on. Even oncocytoma and clear cell carcinoma they are one cell type, but there are many tumors, especially for salivary gland. They can show two cell population, which include pleomorphic adenoma, which is a benign one, but there are other malignant tumors, basal cell adenoma, which is benign but is malignant counterpart, then epithelial, myoepithelial carcinoma, adenoid cystic carcinoma, all these can show two cell population. Now there is one exception is mucoepidermoid carcinoma, which shows two cell components, but both are like squamous and glandular, no basal cell component. While rest of these tumors showing two cell population, usually they have one luminal cell component and second is abluminal, which can be myoepithelial or basal cell component. So here we are looking at one pleomorphic adenoma with two cell types. There are ductal cells and there are the clear cells with clear cytoplasm. These are myoepithelial cells. Higher magnification shows the same ductal versus luminal versus abluminal cells. Again, epithelial myoepithelial carcinoma, you can clearly see these luminal cells here and the clear cytoplasm cells showing this myoepithelial cells. Adenoid cystic carcinoma again can have two populations, luminal and abluminal. Mucoepidermal carcinoma, as we discussed, it can show squamous and glandular population. Here you see squamous population, intermediate cell, glandular population, mucin secreting cells, higher magnification, intracellular mucin seen in the glandular population, while the intermediate cells, these are squamoid cells or squamous cells. Now, morphology of cell is very important, and this table shows you morphology, how it can help in diagnosis. Now, here I want to clarify one thing. When we are looking at all these patterns, pattern of invasion, architecture, cell types, morphology, everything has to be put together. There is so much of overlap, so we cannot take just one feature, like we cannot take just cell morphology or architecture. They are not useful. There is too much of overlap. We have to put everything together and then we can solve this puzzle. So there can be squamous cell type, which we can see in mucoepidermal carcinoma, sometimes in Warthin tumor, squamous cell carcinoma and adenosquamous carcinoma. Oncocytic cell type. Now, basilar cell type, very common, and it is seen in many of these tumors, including adenoid cystic carcinoma, pleomorphic adenoma. It can be seen in some of the basaloid squamous cell carcinomas, although very rare. But basal cell tumors, sialoblastoma, all of these can show basaloid cells. Spindle cells, not very common, but can be seen in myoepithelial tumors and mesenchymal tumors. Clear cells, again, there's a big list of tumors, salivary gland tumors that can show clear cell features. Sebaceous cells can be seen in sebaceous adenoma and carcinoma, but we have to remember sebaceous metaplasia can be seen in other tumors as well. So just spotting sebaceous cells doesn't make it sebaceous adenoma or carcinoma. So just to show you again those patterns, the cell types, squamous cells, oncocytic
Sorry,
cells.
can I just that about a sebaceous gland differentiation? Is there any cutoff percentage in order to
It's
say that
not
it
a
is sebaceous
cutoff.
gland?
There is no cutoff as such. We have to look at the entire tumor and put everything together. So majority of the times
Okay.
when it is metaplasia, we are going to see it's a focal metaplasia. But the majority of the
This is a
tumor will show
focus.
the primary tumor population.
Okay.
So first we have to diagnose that primary tumor. So this can be a problem in biopsy. While diagnosing biopsy, it can be a problem. So that time we just describe it and we can say something. It can be a low grade versus high grade salivary gland tumor. But in an excised tumor, if it is sampled enough, there is no problem. This is showing oncocytic cells, basaloid cells, as you see in adenoid cystic carcinoma, spindle cells. Sometimes you can see it in myoepithelial tumors or many mesenchymal tumors, and clear cells. Again, clear cells can be seen in a variety of salivary gland tumors. Glandular cells, again, salivary duct carcinoma, adenocarcinoma, NOS, all these, again, PSC or polymorphous adenocarcinoma can show glandular cells. Coming to the architectural pattern, there are multiple architectural pattern. Again, we can see here cribriform, tubular, microcystic, papillary, fascicular, and solid sheets. But again, if you look at all these things, there is a lot of overlap. And that's why I keep saying we cannot take this just as a cribriform architecture. So this could be this tumor. That's not so. We have to look at the architecture. What is the predominant type of tumor? What is the cell type, predominant cell type? Whether the tumor looks benign versus malignant, everything has to be put together. In spite of all this, sometimes we may need help of ancillary studies. So this is a cribriform pattern, as you see here, tubular pattern, then microcystic pattern, papillary pattern can be seen in adenocarcinomas, fascicular pattern, especially when there are spindle cell tumors, solid sheets, especially when we are dealing with high-grade transformation or high-grade malignant tumors. Now, stroma, how it can be useful when the stroma is distinct, like it shows mucin. We can say that extracellular mucin, if it's seen, usually it is seen in the mucoepidermal carcinoma, especially in the low grade and intermediate grade. Higher grade tumors will show very little mucin. Mucinous adenocarcinoma can show mucin. Now, chondromyxoid or stroma or basement membrane like matrix, which is very typical for salivary gland tumors and pleomorphic adenoma, sorry for the spelling mistake, myoepithelial tumors, canalicular adenoma, adenoid cystic carcinoma, epithelial myoepithelial carcinoma. So all these tumors can show some matrix which can be chondromyxoid, basement membrane like. When it is present, it points out towards one of these tumors. So this is how the extracellular mucin will look like in addition to the intracellular mucin in these glandular cells in mucoepidermal carcinoma. And this is the matrix. It is kind of, this is a pleomorphic adenoma showing the matrix, extensive matrix in the stroma. So now coming to the immunohistochemistry, what are the immunohistochemical markers that are required for diagnosis of salivary gland tumors? So usually immunohistochemistry is required to identify the cell types, luminal versus abluminal cells. Sometimes there are specific markers to support the diagnosis of tumor, and sometimes they are required for prognostication and to find a potential therapeutic agent. Then we have looked at this details. So that there is a big list of markers for luminal cells and abluminal cells. Most commonly, we use CK7 um, or sometimes EMA for luminal cells. Pancytokeratin is usually not that helpful because sometimes abluminal cells can be positive. Abluminal cells, one of these P63 or P40 is useful, but in addition, there are like SMSC, Soxten, S100. Now, Soxten is not always just a marker for abluminal cells. It can be seen in sometimes acinar cells that we'll see later on. Then there are specific markers like SMSC, S100, Calponin, GFAP, CD10. All these can be used for detection of abluminal cells. Now, there are certain markers that are supporting or specific markers for some tumor types. For adenoid cystic carcinoma, MYB-MIB, but that's not again very commonly used. Usually the molecular studies are done if at all any question is there, although they are not commonly done in our country. But then luminal and myoepithelial cell markers as well as c-KIT can be helpful for adenoid cystic carcinoma. Salivary duct carcinoma, one cell population, glandular cells, but it can be positive for GCDFP, GATA3, androgen receptor, and that can be helpful for diagnosis. CRB2 is a predictive marker. When positive, sometimes oncologists may use it for targeted treatment. Pleomorphic adenoma, again, plaque is one marker, but not very commonly used. Most of the times we use luminal and myoepithelial markers. So we have to understand when we are using luminal and myoepithelial markers, first, we have to identify the histological features and put in certain category, and we use this marker only to support diagnosis. They are not they are not the diagnostic markers. They are the supporting markers. But that's not the case for acinic cell carcinoma. Dog1 positivity can be helpful for diagnosis of acinic cell carcinoma. Although morphology, a good HE section is helpful or enough most of the times for diagnosis. Soxten can be positive here. It is not a myoepithelial cell, but Soxten can be positive. Now, polymorphous adenocarcinoma, secretory carcinoma, they can show co-expression of CK7, S100, Soxten. Secretory carcinoma, further, majority of them can be positive for pan-TRK antibodies. There are certain markers for prognostication like Ki67. If we are in doubt whether high grade versus low grade, especially in a biopsy, we can use it. Androgen receptor and CRP2, I already told you. MUC1 and MUC4 for mucoepidermal carcinoma, but not very commonly used. So, with this background, I'm just going to show you some interesting cases and how we approach to the diagnosis. So, this is first case is a 47-year-old female, right parotid tumor, 2 years with recent increase in size. And this we have seen earlier, this was a circumscribed tumor But this tumor also showed some areas which were infiltrative. Here you can see this is very cellular area. There is this circumscribed tumor, but juxtaposed to that is infiltrative area going into the salivary gland. It looks very cellular. Now there is this low grade area which looks like a pleomorphic adenoma, shows luminal and myoepithelial component and lot of stroma. This is higher magnification. We have seen it earlier. But if you look at the cellular tumor, this is the cellular tumor showing marked atypia, and it is infiltrating the normal salivary gland, which is seen on the right hand side. Sorry, left hand side, and right hand side we see this cellular tumor. And if you see the cellular tumor, it looks like a glandular tumor. So this looks like an adenocarcinoma arising in a background of pleomorphic adenoma, and the diagnosis you know very well. This is carcinoma ex pleomorphic adenoma. If usually there is no immunohistochemistry required, but this is just done to show you how the components can be highlighted. So P63 shows the myoepithelial cells, CK7 shows the epithelials or luminal cells. CK7 in high grade areas, you can see this is strongly positive in those sheets of the adenocarcinoma cells. But these adenocarcinoma cells also express GCDFP, and CRB2 is strongly positive. So this was a case of salivary duct carcinoma. Is a carcinoma is pleomorphic adenoma with salivary duct carcinoma as a carcinoma component. And this is very essential to identify. If we can identify the carcinoma component, whether it is salivary duct carcinoma or sometimes it can be myoepithelial carcinoma, we have to tell them the grade of the tumor. Usually these are high grade. Carcinoma ex pleomorphic adenoma, the carcinoma component is almost always high grade. Now, pleomorphic adenoma and carcinoma ex pleomorphic adenoma, we have to identify the differentiating points. So, capsular infiltration. Now, capsular infiltration may or may not be there when it is within the capsule. The carcinoma component, it is called intracapsular. But there are other features which can be helpful: hypercellularity, nuclear atypia, presence of necrosis, vascular or perineural invasion, presence of metastasis, and benign. But there is a problem usually when there is PA, which is metastasizing, and it looks like a PA. But extensive sampling of pleomorphic adenoma is essential just to rule out if there is any focus of carcinoma ex pleomorphic adenoma. So
can I disturb you again for the
Yeah.
audience?
yeah,
So extensive sampling means what? How much of the tumor should be sampled? If you can
So-
specify the audience.
So commonly when we look at the tumors, usually 4 to 5 sections are enough. But then if we are sampling only from pleomorphic adenoma, so grossing is very important. While looking at the gross specimen, it's not only the glistening lobulated areas, we have to take those fleshy areas as well. So if you are looking at some tumor where FNSC says there is high-grade carcinoma and you are looking at only pleomorphic adenoma or low-grade tumor, then you have to go back and sample more tumor. Now, salivary gland tumors are not really very, very big, but usually 4 to 5 sections are enough if you don't find high-grade areas. And if you are suspecting any carcinomatous component or grossly it shows some different areas, then we have to go back and submit at least 2-3 sections more until we are satisfied. So it's not necessary to sample entire tumor.
Any particular size and number of blocks ratio?
It's not actually specified. Minimum 4 blocks, but if it is a big tumor, try to take at least 1 per centimeter and different areas. Most important is avoid necrotic areas, avoid hemorrhagic areas.
1
Try
block
to
from
sample.
per centimeter, right? I think that's more or less by practice.
And so if it is a big tumor, try to get at least 1 per 1 centimeter like we do it for sarcoma. But what is important is avoiding necrotic, autolytic or hemorrhagic areas. We need to get those fleshy areas and those glistening white, which can be pleomorphic adenoma areas. So going to the next case, this is left submandibular tumor for 6 months in 66-year female. And this was a biopsy we received, and you can see here like duct-like areas, but there is infiltrative tumor as well. There is necrosis. Higher magnification shows duct-like areas with necrosis. If you see this in breast, you may call it as TCIS. So whenever you get this kind of duct formation, necrosis, high-grade adenocarcinoma, first thing we are going to think about salivary duct carcinoma. Now, morphology is usually sufficient, but sometimes usually for salivary duct carcinoma, we do immunohistochemistry just to make sure that this is salivary duct carcinoma and to get some targeted agents. So CK7 is nicely positive, strongly positive. There's another case. This is another salivary duct carcinoma with necrosis and duct-like configuration here. These are androgen receptor positive and CK7 positive, GCDFP also positive. So these tumors can be CRB2 positive sometimes, which we have seen earlier, and CRB2 can be helpful if it is positive. Targeted treatment can be considered, especially those refractory cases or recurrent cases. So this is a unique ISC profile for salivary duct carcinoma. ER beta expression can be seen, but there's a problem with standardizing this antibody. So not majority of the centers are not doing ER beta, but AR or androgen receptor and HER2 or CRB2 can be easily done wherever ISC is available. Going to the third case, this is 47-year female mass involving nasal septum, and this is, you can see, this is the overlying epithelium, and there is this tumor, quite cellular one. This was infiltrative tumor. Here also you can see a very cellular tumor arranged in some trabeculae loose sheets, sometimes some tubular pattern. And then here you can see that probably there are two types of cells, which is very well seen in higher magnification. You have luminal cells and you have cells with clear cytoplasm. These are abluminal or myoepithelial cells. This is another picture showing the same. And if you do P63, the myoepithelial cells are very well highlighted. CK7 highlights the luminal cells. So diagnosis here is epithelial myoepithelial carcinoma. Again, epithelial myoepithelial carcinoma, the morphology is important. The markers, ISC markers, are just to support the diagnosis, to identify the two cell types, especially if you are dealing with a biopsy. Coming to the next case, which is another nasal cavity tumor in a 57-year-old male. And here you can see it's a biopsy, but you can still make out it is kind of not a very circumscribed tumor, probably infiltrative. There are solid areas, probably some microcystic areas. At high magnification, you can see loose clusters, microcystic areas. There is some material or stroma, myxoid stroma is there. At higher magnification, probably it looks like a single cell type. If you are in doubt, we can always do markers. Now this was CK7 positive, nicely. And it was also positive for S100 that time. Nowadays we have an additional marker, that is SOX10. When both are co-expressed, CK7 and S100 or SOX10, and it's a low-grade adenocarcinoma. This is showing multiple types of or polymorphous architectural pattern. This is polymorphous adenocarcinoma. Usually these are low-grade, but it used to be called as polymorphous low-grade adenocarcinoma, but with 2017 classification, we call it only as polymorphous adenocarcinoma. So again, ISC profile is given here. Cytokeratins is usually CK7, low molecular weight, S100, SOX10. CA, GFP may be tried, but usually we use CK7 and S100 or SOX10. So there is another case, 29-year-old female, swelling on the left side of neck for last 8 months with recent increase in size. Now here you can see this is again not a circumscribed tumor. It has a pushing margin, lobulated appearance, but it is directly abutting the salivary gland. You can see the salivary gland in the lower part of the slide, and there is this tumor abutting the salivary gland with some infiltrating globules. Higher magnification, little higher magnification again shows that infiltrative nature of the tumor. And here if you see the tumor cells are quite large with amphiphilic cytoplasm. If there are certain areas with some vacuolated areas are there. Higher magnification, you can see amphiphilic cytoplasm and this nuclei, which are kind of dark nuclei. Higher magnification showing the same. So This is a good case of actinic cell carcinoma, usually diagnosed on good H&E sections. We don't need immunohistochemistry if it is not available. It is not essential for this tumor. But if you have dog one, if you see the dog one, it has particular type of expression, a luminal type of expression, as you see here. It is not that entire cell will be positive. It will show just part of the cytoplasmic membrane on luminal side, which will be positive. So this is dog one. Soxten, which is a nuclear marker, can be positive in actinic cell carcinoma as well. PAS, when available, can be used. So PAS can be positive. So ISC profile is usually cytokeratin. Now mind well, sometimes cytokeratins can be, especially CK7 can be negative in this tumor, but Soxten, dog1, and the morphology. First thing is morphology, and these two markers can be helpful for diagnosis of these tumors. Now there's another, there are few salivary gland tumors. They are recently described, not so recently described now. Almost now they are like 10-year-old entities, some of them. But these are the tumors which are sometimes, most of the times, diagnosed with the help of immunohistochemistry. And there are certain genetic abnormalities has been described in these tumors. So one of these is cribriform adenocarcinoma of tongue. Then there is secretory carcinoma, which was initially called as mammary analog secretory carcinoma. Then there are mucin-rich and sarcomatoid variants of salivary duct carcinoma. And one more thing is high-grade transformation in salivary gland carcinoma, which is otherwise low-grade. So there is one case, this is 55-year-old female, painless progressive swelling involving cheek. And this is the tumor. This has somewhat infiltrative pushing borders, lobulated nature. You can see at higher magnification, small lobules are infiltrating. And you can see there's cribri forming. There are loose sheets and cribri forming and cords. You can see a little bit of papillary appearance, although they are not true papillae. And higher magnification, if you look at the nuclei, it reminds you of something. These are elongated nuclei with clear chromatin clearing with some grooves. So that reminds you of papillary thyroid carcinoma, although it is not a papillary thyroid carcinoma. But when you get this tumor at some odd location, first thing you are going to think about, because it's not a very common tumor, you are going to think about whether it is metastasis of papillary thyroid carcinoma. And this has to be always ruled out, and we have to do markers for this. So this is a tumor, adenocarcinoma, kind of a low grade, composed of cribriform papillary processes, clusters with tumor cells showing nuclei which are oval, clearing, chromatin clearing, and some grooves sometimes. This is higher magnification. This is cribriform adenocarcinoma. Initially it was called as tongue, cribriform adenocarcinoma of tongue, but now it is just cribriform adenocarcinoma. This is again a variant of a low-grade adenocarcinoma of salivary gland, initially described by Dr. Skalova and her team. And it is usually more commonly seen in minor salivary gland tumors. It was initially thought to be exclusively in tongue, but now it can be seen at extralingual site as well. Cribriform pattern, everything we have already described that. This tumor, similar to polymorphous adenocarcinoma, it is S100 and CK7 positive. But it is TTF1 and thyroglobulin negative, that way ruling out papillary thyroid carcinoma. So here, the immunohistochemistry with these four markers can be useful. It's a low-grade tumor. Presence of lymph node metastasis is still can be seen at the time of presentation. Although the lymph node mets are there, the course is kind of indolent in spite of presence of lymph node metastasis. Now, differential diagnosis, we have already discussed metastasis of papillary thyroid carcinoma, but adenoid cystic carcinoma solid variant has to be ruled out, and sometimes polymorphous adenocarcinoma, which is again a low-grade tumor, but lymph node mets are uncommon. There's another
May I
case.
disturb you again?
Yeah.
Will you just go back to the immunostain?
Sorry?
The previous case, the immunostain slide, the previous one. Just go back. The previous one. Actually, there are many okay.
Here I haven't used any
immunostain. आगे चलो पीछे नहीं आगे चलो. You had that CK7 and S100 positivity in this tumor. Actually, we have postgraduates, so we have to teach them. So, what is the pattern of that CK7 and S100 positivity? Is it all the cells randomly stains, or there is distinctive pattern of staining of those two immunomarkers?
So that's why I said co-expression. So that's we have to really understand, especially for postgraduate.
Do you
There
have
are
any
many
slide for that?
I don't think I have that slide in this one, cribriform adenocarcinoma. Maybe it is there in the polymorphous adenocarcinoma, maybe, I'm not sure. Yeah, but I have only CK7 at this point. But it can be positive. But see, the cells both show, like if you look at these cases, there are many salivary gland tumors which can show CK7 and S100 positivity. So those which are two cell type, like pleomorphic adenoma, adenoid cystic carcinoma, they will show mutually exclusive. Like the luminal cells will be CK7 positive strongly, but the abluminal cells or myepithelial cells will be S100 positive. They will show some CK7 positivity, which is not going to be a strong one. But when we look at this CK7 S100 co-expression, there are three tumors we can think about is polymorphous adenocarcinoma, cribriform adenocarcinoma of tongue, and secretory carcinoma. All these three can show, and there are those one cell type tumors, and all those cells, majority of the cells, they will be CK7 positive, majority of the cells, the same cells will be S100 positive. We can also use Soxstain for secretory carcinoma. We can also use pan-TRK for secretory carcinoma, so that can be helpful. So just expression of CK7 and S100 is not diagnostic for single tumor. As I said, first look at the morphology. Morphology, we have to make some differential diagnosis or make a list of 2 or 3 tumors, and then only we can use this immunohistochemical markers to make sure that we can support one diagnosis over others. So immunohistochemistry is never used at the expense of morphology. Morphology is most important. So let's go to the next case. This is a 14-year-old male, painless swelling on the right side of neck, increasing in size for past 6 months. You can see there's this salivary gland. It's kind of a circumscribed tumor, but it could be infiltrative in other areas. You can see this area, you have a lot of secretions here, and there are these sheets of the cells, and you see those secretions here as well. So there are vacuolated cells. Again, here I think we can make out that probably this is only a one cell type tumor with lot of secretion, no typical chondromyxoid stroma seen. Now here the CK7 is nicely positive, diffusely positive, all cells are positive for CK7. Mammoglobin is positive. And this is a case of secretory carcinoma. Now, these are the cases where you can see the CK7 mammoglobin, or you can have S100 positive in all these cells. So this is a case of secretory carcinoma, initially called as mammary analog secretory carcinoma, and it is associated with ETV6 gene rearrangement, which was initially fish was used for that, but nowadays pan-TRK antibody is there, and it can be used for diagnosis of these carcinomas. It's locally invasive and shares histological, immunohistochemical, and genetic features with the secretory carcinoma of the breast. Now, differential diagnosis is usually as actinic cell carcinoma, cribriform cystadenocarcinoma, mucoepidermal carcinoma. But again, a good HE section can support this diagnosis over others. And if required, we can always use immunohistochemistry. So as I said, actinic cell carcinoma will be DOG1 positive. Mucoepidermal carcinoma will be showing glandular and squamous cells. And cribriform cystadenocarcinoma will not be positive for mammoglobin or GCD. So clinically, it is a low-grade carcinoma. Prognosis is favorable and ranges from slowly growing tumors, and infrequently it can show high-grade transformation as well. Now coming to our last case, painless swelling on the left side of in a 35-year female, but it is increasing in size for last 3 months. And here you see the tumor. The tumor is infiltrative, no doubt. It is almost reaching the ink margin. As you can see, there are areas cellular, and in addition to that, there are areas which are less cellular. Now this less cellular area, they show cribriform and solid pattern. Probably there are 2 cell types where we can use the immunohistochemistry just to make sure, but looking at the cribriform pattern, gives you indication that probably we are looking at adenoid cystic carcinoma. But if you look at this high grade or this solid areas, this is showing a very high grade tumor. There are areas of necrosis, although there is this some cribriforming is there. Then the nuclear grade is quite high with lot of mitosis, higher magnification. You can see the mitosis. You can see the large nuclei, prominent nucleoli. So definitely we are dealing with a low-grade tumor on one side, which is intermingled or juxtaposed with a high-grade tumor. Now let's look at the CK7, which is showing differential expression. The luminal cells are nicely positive, abluminal cells are not so positive. These are the low-grade areas. P63 is positive in these low-grade areas. You can see the nuclear expression. Ki67 was kind of a lower side in this low-grade area. CKIT was also positive in the luminal cells in these low-grade areas. But if you see the high-grade areas, CK7 diffusely positive. P63 negative. So this is adenocarcinoma component, high-grade adenocarcinoma component adjacent to otherwise kind of a low-grade tumor, which looks like an adenoid cystic carcinoma. Ki67 in this high-grade component is very high. And CKIT, now remember, CKIT is not diagnostic of adenoid cystic carcinoma. Any high-grade tumor also can be CKIT positive. So this high-grade component of this tumor is CKIT positive. So this is a case of adenoid cystic carcinoma with high-grade transformation. Now it is very, very important. And here again, the question of adequate sampling is essential, because as we know, adenoid cystic carcinoma, we decide the grading based on the solid component, whether it is absent, whether it is less than 30%, more than 30%. So those with more than 30% solid component adenoid cystic carcinoma show less favorable prognosis as compared to those without solid component. But when they are associated with this high-grade transformation, the prognosis is much worse. And this high-grade transformation can be seen in other low-grade salivary gland carcinomas as well. So this was initially known as dedifferentiation, and it is usually a low-grade carcinoma intermingled or juxtaposed with high-grade tumor. It is seen in a variety of salivary gland tumors, including adenoid cystic carcinoma, acinic cell, secretory carcinoma, epithelial, myoepithelial, polymorphous adenocarcinoma, low-grade mucoepidermoid carcinoma, highly rising clear cell carcinoma, and all of this. So, but most of the times we see adenoid cystic or acinic cell carcinomas, epithelial myoepithelial carcinomas have been described too. Now, this high-grade transformation, how to identify? We have to identify the low-grade component, and in addition, there is always this high-grade component, usually which shows a solid growth, large nuclei with lot of nuclear atypia. There are frequent mitosis, necrosis, and Ki67 labeling is high if required. And these tumors are associated with higher rate of recurrence, frequent nodal metastasis, and poor prognosis. So with this, I'm just going to show you the genetic side of genetic abnormalities. This is altogether a different topic, which is more and more is going to be important for diagnosis of salivary gland carcinomas or tumors, even benign tumors as well. Although not very commonly used at present in our country, it can be always useful in problematic cases where we cannot decide benign versus malignant, especially for pleomorphic adenoma or certain rare variants of other carcinomas. So with this, I'm going to conclude this talk, and just a take-home message we need to understand is salivary gland tumors are diverse and can be usually accurately diagnosed on HE sections and sometimes well near ISC. Clinically, size of tumor, grade, nodal involvement margins are very significant. Dedifferentiation can be seen, carries worse prognosis, and has to be identified when, especially in case of rapid growing tumors and large tumors. Recently described entities, we should be aware of them. Molecular studies may be useful for identifying potential targets for the treatment. And I would like to thank my colleagues in head and neck pathology. Dr. Shubhada Kane was our ex-head of the department, and rest of my colleagues, Dr. Munita, Neha, Swapnil, and Katha, our head and neck disease management group at Tata Memorial Center, and these beautiful photographs. All of these are like because of our histotechnicians, their hard work. My other colleagues and residents at Tata Memorial Center and ACTREC. Thank you very much, all of you. This is ACTREC at Kargar, and this is Hall of Fame at Leh, Ladakh. And now, any questions?
Shranti, Dr. Amita has not come.
Yes, ma'am, she couldn't join.
She
Madam,
couldn't join.
good
Okay.
questions are there.
Anybody amongst the audience?
Yes, we
You
have
can come up with,
time.
I think all of you can unmute yourself and
Yes.
then ask questions.
Should I stop sharing, or you want this still to be there?
Good morning,
You may
madam.
stop. There is nothing in this now.
Yeah.
But anyway, you can just leave it in house. So
It's
anyway,
okay. If required, I can
anybody,
stop.
anything? Dr. Varsha, you want to ask something?
Good morning, madam. This is Dr. Vanita here from Jamshedpur and
okay.
Tata Memorial Hospital.
Hello.
Yeah, yeah, please ask. Go ahead. Go ahead. Ask anything.
Madam, I just wanted to ask that we are actually dealing with core biopsies, most of them diagnostic core biopsies, and after the diagnosis, if required with IHC also, and the staging as per the radiological staging, then the final mode of treatment is decided whether they go for excision or for radiotherapy, then followed by excision, like that. So, sir, madam, I just wanted to ask that for core biopsies, how much precise we should be in diagnosing the salivary gland tumors, because the tissue is really very less, and to qualify it to the exact subtyping, sometimes it becomes very difficult. So how do we go about that?
So I agree with you. This is always a problem, especially with core biopsies. Sometimes even for minor salivary gland tumors, mucosal biopsies, we have this teeny mini biopsies, and we don't know whether we are looking at the representative tumor or not. But whatever we see, we have to specify. So usually, sometimes if we cannot specify the type of tumor, at least we try to give them whether it is low grade versus high grade, especially for parotid or submandibular gland. Minor salivary gland, again, they are going to go for acquired excision nodal dissection. If they are having any problem, they may ask for frozen section. We do get biopsies, core biopsies, but not so often in major salivary glands. Whatever the biopsies, they are usually for mucosal salivary gland, minor salivary gland tumors. But we do get sometimes, if we cannot say anything further in, especially if we cannot specify what type of tumor it is, we don't even know whether it is salivary gland origin or not, and we know it is, it may require ISC, and it is going to significantly affect the treatment decision and the extent of surgery. Then they will go for a core biopsy, but not always for major salivary gland.
Thank you, madam. Especially for the submandibular gland, madam, as you said that the same thing. Sometimes we are asked to qualify whether it's a high grade or not. So in the representative tissue that we get, we can just tell about the features, that the solid portion and all. But then, madam, it is just a part of the whole lesion. So how correct we are in exactly saying that this is a low grade tumor?
But
Or
that's
should we
always
err
a
on the
problem.
higher side?
That's always a problem everywhere. Where?
Yeah, in continuation with what Dr. Vanita has been asking, I was going to ask you that only. How good is the correlation between the core biopsy and the final diagnosis?
See, the core biopsy as such, most of the time it can be representative, but as I said, when we look at those high-grade transformation or carcinoma is pleomorphic adenoma, if it is not representative, it is not going to be correct. So basically, if anybody is going to go for core biopsy, there is always initially a problem on FNSE. Now, in that case, ultrasound guided, if they are doing it, suppose if they have this ultrasound features where they think it is kind of a high grade tumor, and if they can, guided biopsy can be obtained, or biopsy can be obtained in the multiple areas. Like the way we do for FNSE, we just poke in different direction. It is not always possible for core biopsy. So core biopsy, we most of the times it can be diagnostic, but not always. It is entirely dependent on the person who is doing the biopsy, and they are targeting the right area. And that is problem everywhere. It is not only for parotid gland. It is also even for oral mucosa. How many times we see there are these mucosal biopsies, they say it's a tumor, and we just get the superficial portion. So entirely depends on the person who is giving your biopsy.
Yeah. I mean, I have been also facing that kind of a problem. Like
That's going to be
many
there.
a times it is not representative, and they feel they have gone into the correct area, but many, and sometimes you feel scared ki this may not be the whole picture. This might be just the tip of the iceberg, like
See,
that.
that's why the way we write our report, in this biopsy, we see this tumor or this kind of a lesion. Now, that if you are not getting those higher grade areas and not the representative picture, that's not our fault. So that has to be like when you are talking to your discussing with your surgical team, you can always tell them that this is just, it can be tip of iceberg, maybe it may not be representative. That can happen everywhere. That is not only for salivary glands. In any other organ that can happen. And there are in literature people say that there is some upgrading is there. It's there for prostatic adenocarcinoma, it's there for sometimes in breast tumors also. So that's always a problem with representative small biopsies.
So, would you prefer a core over? I mean, the FNAC is better or core is better?
See, that depends on really who is doing FNAC or core biopsy. Honestly, FNAC usually in good hands and good staining, most of the times for major salivary glands is going to be adequate. But there are going to be instances where we cannot say anything beyond maybe if I can say benign tumor, good. If I say uncertain malignant potential or suspicious for malignancy, then our surgeons will decide whether they want to go for core biopsy or they will go for frozen section.
So
Now,
you,
now, if I am talking about some round cell tumor or some kind of a spindle cell tumor, then I think it's better to get core biopsy because we have to identify them. If we are not thinking of any primary epithelial salivary gland tumor, if we want to rule out something else, we have to have ISC. Sometimes, if required, molecular. In that case, there is no alternative for core biopsy. There has to be core biopsy with us because some of these tumors may not require any surgical excision at all. Just chemotherapy will be sufficient.
so with
Exactly.
suppose if we
Okay.
say sump on the FNAC diagnosis, that category of 5, sum
For 4B.
4B, yeah, 4B. So then the core would be advised or straight away
It is not, see, everything is entirely depend on their clinical and
clinical
radiological
practice.
impression. So if radiologically and clinically they think it is a low grade lesion and they are anyway going to go for surgical excision, they will go ahead and do surgical excision. There is no need for core biopsy. So everything has to be put together. It's not only FNAC. This is like FNAC, radiology, and clinical.
I guess the decision making will come if
I
we are
think,
dealing with started.
how many more questions you have? There are a few questions.
No,
I
madam,
think.
madam, excuse me. Dr. Bharat has a question. Dr. Bharat, Rekhi.
Yeah.
Bharat also,
Please
and Rina also.
unmute and tell.
Yeah.
Yes. Dr.
Bharat
Bharat.
has put down in the chat box. Dr. Asawari, you can refer to the chat box.
Yeah. And, Bharat has asked me literature on cytomorphological diagnosis of mask and certain tumor-like lesions in histopath. So the thing is that mask and other these rare tumors diagnosing on cytomorphology may not be always easier. But we can always say that this is a low-grade tumor. One of the differentials include, but it's not that easy. These tumors are, as it is, uncommon, and diagnosing them on cytology is not so easy for us. Most of the times, it is the acinic cell carcinoma or salivary duct carcinoma can be easily diagnosed. All of us we know adenoid cystic carcinoma, pleomorphic adenoma. If the aspirate is good, we can easily diagnose on cytology. So there are some areas where we can easily diagnose them on cytology. There will be some lesions, especially polymorphous adenocarcinoma or those other low-grade tumors where we'll end up calling just like possibly it is a low-grade tumor and cannot exclude carcinoma. That's how we can say.
There are two
Then
more
one more.
questions. Please see in the chat. Yes.
There's
So
Dr. Rina's also, I think. There's one more
Rina
question.
Kumar.
neuroendocrine component in acinic cell carcinoma. I'm sorry, I really don't have any much exposure on this. I haven't studied them, so I wouldn't be able to answer that question. It's a quite rare thing. So
can I comment something? Ma'am, actually, I encountered a case of acinic cell carcinoma. First FNAC was done. It was diagnosed as adeno-CA. Then the histopath came to me, and there were a lot of neuroendocrine component in that. So 2 cases I have seen. So I wanted to know your experience, whether it is such a common thing or rare thing. And I
is not
reported it
common.
as arsenic with neuroendocrine differentiation. That was my diagnosis in this case. Even I got to publish that also.
So it is high-grade lesion, neuroendocrine, right?
Yes, ma'am.
So it is some kind of hybrid tumor. It is not arsenic expressing this. It is going to be some hybrid, and we do see hybrid tumors, although rare. Hybrid tumors are possible, and we can get them. This could be one of those high-grade transformation in otherwise low-grade tumors. That could be it's probably representing that. And
Can't it be only arsenic cell carcinoma with neuroendocrine differentiation?
Arsenic cell carcinoma, so high grade and showing neuroendocrine, it is, I haven't heard of anything. What I feel is it's going to be, if you are going to have arsenic cell component, arsenic cell component.
May I ask Varsha some question? Do you have the immunohistochemistry for those 2 tumors of yours? Was
Yes,
there any
I did.
differential immunohistochemistry panel, expression?
Ma'am, synaptochromo CD56 was positive in those areas with neuroendocrine differentiation.
And
And
arsenic cell area?
dog 1 was positive. Pass with diastase, I also did.
So
Pass with
you
and without
had
diastase, and
separate,
dog 1 was
Maybe the
positive.
area where you felt arsenic cell was degenerative changes of the neuroendocrine
dog 1 may
component.
not, dog 1 positivity points out toward arsenic cell, but you had arsenic cell area and intermingle with that neuroendocrine. So
Yes,
this
ma'am.
could be one of those high-grade
Dr.
transformations.
Reena, you want to say something? I think you want to say something, Dr. Reena?
Dr. Asawari, please see that last question. Key 67.
I think there is one more question. Dr. Sranti, there is one more question of Ki67 cutoff for benign and versus malignant.
So there is no cutoff. There is no cutoff because Ki67 benign tumors is going to be low, no doubt. Maybe in the range of 1 or 2%. But if you are dealing with pleomorphic adenoma rich in myopithelial cells, you can have a little bit more. Of course, you are not expecting something beyond 5, 6, 7% in benign tumors. So there is no specific cutoff. For salivary gland neoplasm, Ki67 is just used as a supporting marker. First, we have to make the diagnosis on H&E. First, look at the cytology. Is it showing any evidence of malignancy? And then only we use Ki67. And I showed you 1 or 2 examples where we use Ki67 to differentiate between low-grade versus high-grade transformation. I think second, Bharat also asked about lymphoepithelial type lesion. So this can be another pitfall actually in cytology, especially when I am getting it from submandibular gland. If we get an FNA and then it may be diagnosed as metastatic carcinoma. So that there are pitfalls.
Dr. Daphne, all this, ancillary technique or adjunct, we all the time say adjunct. We don't use them as a primary diagnosis. So like I think Dr. Asawari started off with the morphology.
Yes,
I think that's a very important statement which they have made.
Morphology is very good.
You have to use in addition to the H&E. H&E is the most important component of any histopathology. And after that, you go ahead and depending on the situation which you are dealing with, you look into something more. Otherwise, H&E, everything is going to be based on H&E. You have to have very good concept about your morphology. That's very important part of it. I think with this, I think we should say, we have to thank you, Dr. Asawari, for extensive talk. Thank you very much. Thank you everyone who has attended the session. Thank you very much.
Excellent presentation. Thank you, Dr. Asawari. Excellent presentation.
Thank you.
In a short span, you finished everything.
Sure. Thank you very much.
And all that.
Thank you
so much.
Thank you. Bye-bye.
Bye.